This program is brought to you by Emory University.
Good morning, and welcome to Cardiovascular Grand Rounds. Today our speaker is Goyal. Abhi's associate professor and has appointments both in epidemiology, public health, and cardiology. Abhi's sort of the new triple threat. He understands clinical medicine, he understands computer and IT systems, and he understands people and how to get people to work together on quality projects. He's really had a major impact in our division and within the hospital in getting our groups to work on a variety of things, whether it be management of acute myocardial infarction, and he's going to talk about some of the quality initiatives here at Emory and around the country. Abhi.
Andy, thank you for that kind introduction. I appreciate it. This is a terrific institution, I hope that bears out as I talk about the data and some of the acknowledgments that I have toward the end. Let's see. Okay. So this is the outline for my talk. I actually want to spend almost half of it talking about Medicare payment reform as a backdrop for the efforts that we're making here, and SGR repeal and what the merit incentive program looks like moving forward. It can be a bit daunting, but I took a stab at it to put context to all of the quality and value efforts moving forward. Okay. And so if I were to take Medicare payment transformation, the movement can be summarized as volume to value, or at least that's how the media often puts it. And I thought to break it up into 6 different components. And I'll go through each one of these 6 in a little bit of detail in terms of how we've moved along that continuum. So first, the era of fee-for-service and the sustainable growth rate formula. So this was enacted in 1997, and it was really Medicare's attempt to try and set limits on how much physicians were reimbursed as related to total macroeconomic indicators and total Medicare spending. So case volume, regional cost, GDP, these all factored into the physician targets that Medicare set for physicians. Well, not a surprise, when it's fee-for-service and it's linked to volume, it didn't take long before spending exceeded the targets that Medicare had set, and before the SGR had to kick in and target cuts specifically. So the formula states when spending is greater than targets, cuts will be implemented moving forward. And some of those cuts, what it specified is if a cut didn't happen in one year, it would roll forward and be added to the cuts for the following year. And large cuts were therefore threatened up to 30% in any given year. And Congress postponed this, recognizing that would be devastating, not just for physicians, but for healthcare as a whole. And so that's the backdrop that we were working with for a good 11 years, was the threat of the SGR and the cuts that it would bring. This was still during SGR, but the 2007 to 2015, I would call the era of the emergence of quality and value-based care. And there were several projects and research initiatives that demonstrated in the early 2000s that there was a direct link between performance and achieving quality indicators and outcomes, both in the hospital and in the outpatient setting. And so in 2007, the PQRI, or Physician Quality Reporting Initiative, it was changed later to PQRS, or system, was initiated, and it consisted of about 74 measures that was claim-based only. And then with each subsequent year, it grew and it became more permanent within our structure. So it went up to 119 measures. They added a registry component to PQRI, It grew to 153 measures. And then in 2009, they also introduced the electronic health record incentive and e-prescribing as well. And then in 2010, it was expanded further through the Affordable Care Act and GPRO, which is the group option for participating in PQRS. If you're a practice of 100 providers or more, you are now automatically required to participate in GPRO, and that's what the Emory Clinic, the Emory Specialty Associates, and large practices participate in. And so it was clear we were moving in this direction of quality. And around the same time, meaningful use, which is a bad word around here, that came to existence as well. And so it was envisioned as having 3 stages: data capture, advanced clinical processes, and the thought was we would get so good at using EHRs that we would be able to demonstrate that they actually improved patient outcomes, that errors would stop and outcomes would improve. This timeline has been proposed. We're behind on this timeline. We are, of course, nowhere near demonstrating improved outcomes with electronic health records, as some of our projects will demonstrate coming up. So then the dialogue began to shift from quality to value. So what exactly is value-based care? So high value healthcare, value has 3 components, and high value care is high quality, it's associated with high patient satisfaction, and it's associated with low cost. And the term value has been in other industries for 20, 30 years, and it's taken a long time for healthcare to catch up. From the payer standpoint, the definition is fairly simple. It's still fee-for-service, but with incentives and penalties, or as Medicare likes to affectionately put it, adjustments. They don't like to say penalties because they know people get funny about it, so they call everything a payment adjustment, particularly when they're talking about penalties. All right, so, and then further on in this transition, Medicare introduced what's called the ValueBased Modifier, again, which is proportional to quality, patient satisfaction, and the cost of care. In the outpatient setting, in the GPRO setting, the GPRO performance rating was used to designate quality. The CG CAP survey was used to designate patient satisfaction or consumer group, and the health physician survey. And the cost of care was a synthesis of several cost measures. And that included Medicare cost per beneficiary. It included total capita cost for overall care. It included total capita cost for disease-specific, for conditions including diabetes, et cetera. And so from that came a value called the value-based modifier, which could be a little bit below 1, or it could be higher than 1. And you wanted it to land on the greater than 1 side, because your value-based modifier would be multiplied by the fee schedule for any service that you rendered, and that would be your payment. And then they basically threw this curveball on you and said, this is going to be introduced in 2015, and by the way, what you did in 2013 determines your value-based modifier for 2015. And everyone was like, well, where is this coming from? And so that's now the rule, is that whenever you perform in a given year, 2 years from now, it'll be reflected in your value-based modifier in terms of your performance. And so these rules were coming at us pretty quickly. Okay? The clinic now for 2 years in a row has gotten reports on their value-based modifier from Medicare. This is an example. This is not Emory's report, but this is kind of a generic report. And the way the reports are basically shown is every single practice that participates in GPRO is represented by a dot on this graph. You have one axis that's cost, one axis that's quality, and this is the quadrant you want to be in. You want to be high quality, low cost. And if you're high quality, low cost, you basically get 3 times some multiplier added to your overall payment for each service that you render. A lot of effort has been put into Emory in the past couple of years. This is not us, actually. We are kind of over here. We're slightly higher than average in terms of quality, and we're cost neutral compared with the rest of the group. And after having gone through the exercise a couple of years with Penny Castellano and others, and as this graph actually bears out, the vast majority of practices fall here in this middle quadrant, this neutral quadrant, where they get no adjustment either way from their physician fees. So to actually get into this quadrant is a pretty tall order. This is constantly evolving. But that's, we're now getting these QR-UR reports, as they're called, every year to indicate what our value-based modifier is. So now this takes us to 2015, okay, and we'll talk about MACRA and the repeal of the SGR, okay. MACRA stands for Medicare Access and CHIP Reauthorization Act. You count on Medicare and Congress to actually put an abbreviation within an abbreviation, and so that's what they did. And so CHIP is the Children's Health Insurance Program, and this was passed in 2015, and it was a rare example of bipartisan support. Both parties actually had interest in doing away with the SGR, and this was actually hailed as one of the very few successes of actual bartering and give and take to come up with a solution that was generally regarded as a good move. And so what exactly did the MACRA do, kind of high level? First, it repealed the sustainable growth rate formula. That's why it's also called the SGR fixed. And it averted a 21% cut in physician fees that was scheduled to take place this year. Okay. It extended the Children's Health Insurance Program for 2 years. CHIP insures about 8 million children up to the age of 18, and it also helps to insure pregnant women and also babies in utero through some state programs. And so that's approved for another 2 years. MACRA also established 2 payment models to start in 2019. One is called the Merit-Based Incentive Payment System, shortly called MIPS. Okay, and I'll refer to MIPS throughout the next 10 minutes or so. And the alternative payment models, the APMs. Now, it's important to know that these are actually 2 different payment pathways, and so that's a key thing to keep in mind as we go over the next set of slides. And kind of a bold statement, but MACRA actually said that we want interoperability among EMRs to be achieved by 2019. I think it'll be very interesting to see whether Cerner and Epic CEOs can actually get together and deal with their interoperability issues. That's been on the radar for a long time, but has not happened. In 2019, we'll see if a law can force that to happen. What's anticipated to happen from 2016 to 2018 now is the MIPS rulemaking and transition period. So it's fine. MACRA said, okay, this law is there and we're going to introduce a MIPS and an APM. Well, what exactly goes into the decision making for MIPS, the Merit Incentive Payment System? All right, so what's been proposed is that instead of cuts, actually, the 21% cuts that were averted when the SGR was repealed, it's now proposed that for the next 4 years, including this year, the physician fee schedule would increase by 0.5% per year. And to help offset this cost, because everything Medicare does basically has to be cost neutral. Something, if you're going to increase something, it has to come from somewhere. And so it's been proposed that Medicare premiums will increase for high-income beneficiaries, which is anticipated to impact, they say, sort of the top 2% of income among Medicare beneficiaries. The current incentive programs of PQRS, the group reporting option, meaningful use, and the value-based modifier, they will continue through 2018. And this is also what's called a rulemaking period, where several stakeholders will be proposing quality measures for MIPS to happen from 2019 and beyond. Okay, and ACC has been on the ball in terms of trying to anticipate from this. They've already presented to leadership regarding what they anticipate is going to happen. So they plan to participate in drafting plans for MIPS and the alternative payment measure development. There's going to be a public comment period. The HHS website, the Health and Human Services website, will post a final plan, and there'll be an annual progress report. And actually, as part of MACRA, $15 million per year is actually earmarked to help develop these quality measures that are going to be used. The measures that are part of MIPS will include outcome, patient experience, care coordination, and others. And so, I think several professional societies, cardiology, I know neurology is also planning something pretty robust. They're trying to get involved in this, and really advocacy is going to be the key part in helping to shape exactly what MIPS is going to look like. Okay. Fortunately, registries are going to be a big part of that, and it's anticipated that those societies that have registries in place are going to be in a better position to propose and respond to this. And so, as you know, cardiology through the NCDR has several registries. These are the ones currently that we participate in, circled in red, the hospital-based registries. I think very shortly we'll have the Pinnacle registry introduced on an outpatient setting as well. Now, what are some of the details that are going to be defined in MACRA and in the MIPS and in the alternative payment models? Well, let's take a look here and see. So as I pointed out in the beginning, there are going to be two payment models that are deemed sort of separate paths. The default for the majority of systems that are already in PQRS and GPRO and meaningful use is the value-based payment model, which is the merit-based incentive program, or MIPS. Okay, so MIPS basically will retire all of the individual incentive programs and combine them into one score, the MIPS composite score, that has 4 components to it: quality, resource use, EHR meaningful use, and practice improvement. So these 4 components will go into MIPS, and of course the devil's in the details in terms of all of these things that have to be worked out from 2016 through 2018. And then a separate model will be the alternative payment models. ACC has put together a slide that demonstrates what each of these components look like. The initial proposal is that quality will constitute 30% of the MIPS composite score, resource use another 30%, EHR meaningful use another 25%, and clinical practice improvement another 15%. And a lot of these things we're already doing, and so all of the efforts that we've been responding to as an institution, we have in place to, none of the individual components are a surprise. Okay, what remains to be seen is how all of that will be synthesized and aggregated into one composite score. So on the one hand, it can be daunting to hear about these changes. On the other hand, really since 2006, since we sort of got on the scene with UHC, we've really already been adjusting as an institution and as a division with NCDR and with the whole division's focus on quality and outcomes, surgery with STS and NCDR as well. And this is, I think we're moving in a direction where we can at least, I guess in John Fox's term, he used to have a quote, you have to participate and don't embarrass yourselves. So I think, we're in a position hopefully to not embarrass ourselves and to participate. And I would even say that, a number of our group actually are advocating at the national level, and that's very helpful. Okay. A couple of slides I'll show courtesy of Karen Joint, who has an appointment in the Harvard School of Public Health, also in cardiology, and presented to the NCDR Management Board and also as a consultant to the U.S. Department of Health and Human Services. And she's considered a national expert on health policy reform. And this graph summarizes sort of what can be expected as MIPS gets rolled out. Okay, so from 2015 to 2018, about a 0.5% increase in the physician fee schedule per year. Okay, and then after that, you can see from 2019 to 2024, stable. No increase for the neutral zone, okay? And then based on your composite score, if groups perform well, they will actually receive incentives. For those that perform poorly, they will be penalized. And this is not based on an absolute cut point. This is based on competition with other systems. That's how it's going to be cost neutral. In order to pay incentives to high-performing systems, you have to take away from those that are not performing as well. And it's even sort of targeted that those that are performing exceptionally well, which is at least the top quartile, if not better, that they will have bonuses that are above and beyond, perhaps even higher than what's represented by this purple curve. Okay, it could be quite a multiplier to, it's going to be on a graded curve. So if you're in the top quartile, you'll be in the exceptional tier. But even within that, there's going to be a continuum such that if you're, for example, in the top 5th percentile, your bonus may be 20% beyond your sort of your basic fee schedule, something of that nature. And so that's sort of what's been presented as what we can expect from 2019 to 2014. And you know, in these past couple of years, when we were looking at individual incentive programs, maybe a 2% bonus here, a 1% bonus here, it was a little bit easier to say, well, that takes too much work for us to participate in, and we're not going to do that. That's okay. Now when you're talking about 9, 10, 11%, that kind of thing, that's a lot. So it's kind of like, all right, this makes it seem pretty difficult to be a small practice and survive moving forward. MACRA does have some concessions for smaller groups. They do permit some small groups to kind of join other groups as virtual groups in order to presumably thrive under the new law. But that's, I think clearly there's still some advantage as a whole to belonging to a large system that has the infrastructure in place to succeed. Right? So that's the MIPS component. Now, what about the alternative payment models? And this is sort of a little bit even more nebulous. There are some centers around the country that are attempting to do these with variable success. Generally, the term alternative payment model includes among the following: patient-centered medical homes, accountable care organizations, bundle payments. These are just some examples of how what they would look like. They are generally supposed to be risk-bearing. You know, I think our shared savings plan with Blue Cross Blue Shield and Aetna can be considered in this bucket of an APM. And we'll get into that sort of what about those health systems that do both a combination of some MIPS in terms of getting some payments and some APMs and sort of some payments. And then they also have quality measures and EHR requirements as well. This is another slide courtesy of Care and Joint where in addition to, so this is superimposed on the MIPS slide that I presented. So you can remember with MIPS you're either neutral or you're incentivized if you're doing really well or penalized if you're poor, if you're doing poorly. So APMs, they're really a disruption of the current fee-for-service paradigm, and you're looking for novel ways to deliver care that's really based on value, not volume. So you're not necessarily going to be rewarded for doing more. Just to clarify, MIPS is still very much sort of rooted in fee-for-service. The more you do, the more patients you see, the more you get paid with some incentives and with some penalties. So fee-for-service is not going away, all right? That's often a myth, and I'll get to that in a moment, but that's often a myth that's said. APMs are really different. They're trying to change the paradigm of how care is delivered. And so instead of the uncertainty of whether you're going to be neutral or rewarded or penalized, if your system has committed to achieving a certain level of care that's in the APM model, then Medicare will give you a 5% bonus each year through 2025. And thereafter, it'll increase actually by 0.75% per year, whereas the MIPS increase will be less robust at 0.25% per year. And so over time, the thought is that APMs will be really the model of the future that is encouraged. Having said that, there are a lot of details to be worked out. I don't think fee-for-service is going away, kind of as a foundation for all of the incentives that are happening on top of it. Okay. What exactly constitutes the alternative payment model in terms of who qualifies for that? So just because you do some alternative payment model with some shared saving plan doesn't mean that you can go in as an APM for your whole institution. And so what's been put forth in the law is that in 2019 and 2020, 25% of your total Medicare revenue has to come from APMs for you to qualify as an APM institution to start getting the APM bonuses. By 2021 and 2022, that has to be 50% of the overall revenue when it's combined with all payers, not just Medicare, but all payers can be included. 2023 and beyond, it's 75% of the total revenue that's expected to come from APMs if you want to qualify as an APM institution. Okay. So then the final segment is 2025 and beyond. Is that going to be termed the era of alternative payment models? I put a question mark in there because that's a lot of this is uncertainty in terms of how the law is actually going to take shape and rulemaking. But I think it's also fair to say that a lot of this is media hype in terms of taking this, building on the fear, and trying to figure out what exactly is real and what is not. And so there have been several well thought out perspective pieces in New England Journal, JAMA, Health Affairs, et cetera, that really question the hype that's going into APMs as sort of the dominant form of care 10 years from now. I mentioned this, that after 2025, it's been proposed that those on the MIPS plan, the Merit Incentive Payment System, which is again founded on fee-for-service with incentives, there will be a 0.25% increase per year and a higher increase per year for those that are truly participating in alternative payment models. Okay. And that's borne out here, just going back to that graph where from this point on, presumably the increase will be a little bit steeper for the alternative payment models than it will be for the MIPS plans. All right. So just before I wrap up this section and get into data for the second half of the talk, just a couple of myths. Fee-for-service is going away. I don't think that's the case. We're very rooted in fee-for-service as a country. The MIPS plan, even though there's a lot of talk about incentives and penalties and adjustments, quality and value, it's based on a fee-for-service model. You still get rewarded for volume, for patients you see, to an extent, of course, the procedures you do, where that's going to fall out in all of this, with the resource use, we'll have to see. But the more patients you see, the more you bring into the system, the more payment your system will see. Okay, so that's still part of MIPS. Another myth, we are all moving towards APMs. It's been acknowledged it's not the best approach for everyone. And the way the law is written, it's not saying that MIPS and the value-based system is going to be eliminated. That's our current reality. It's still going to be a reality 10 years from now, according to the law. And while they may encourage APMs, really there's a lot of uncertainty about how that's going to take shape. Okay, and then finally, just to kind of balance it, the repeal of the SGR means physician payment won't be cut again. That's not probably true either. Okay, I mean, basically in one or two fell swoops with big laws, they can make these big changes to what's happening, and there's already some question about how this is going to, I think actually on a couple days ago, October 28th, Congress passed another law extending hospital cuts from Medicare by 2%. That was happening sort of year on year, and so hospital cuts are now going to continue through 2025. How do the hospital cuts balance out with the physician increases when you're part of a large system where we're all in this together? Okay, presumably hospitals and practices, presumably we're going to try and pull resources, and if one's penalized and one's incentivized, how does that balance out at the end? All right, so there are many questions in terms of how this is going to take shape. How will MIPS be implemented for large practices? As I just mentioned, what's the balance between the increasing physician fees and cuts to hospital reimbursement? Is there any provision for academic health systems? Because Medicare has traditionally funded our house staff and fellow training program. And how do we implement an alternative payment model in a large specialty practice or in a multi-specialty practice that's heavily subspecialty driven?
Abby, can I ask a question before you move on to the
Sure.
other part? Is there any incentive for building APMs in if you don't meet the threshold to be an APM provider? Because it seems like, for example, coronary bypass bundling or valve bundling is an approved APM that we could pretty easily implement. But it's very hard to envision us meeting that threshold as an institution to be an APM provider. Is there any incentive to build in APMs short of meeting that threshold to be an APM provider?
Yeah, that's a great question. There is. My understanding of potential incentives is even if an institution, if they're making strides towards incorporating APMs into their revenue and payment scheme, if you're close to a target for an APM but you fall short, and you've sort of put your eggs in that basket and you're therefore not doing well in MIPS, they may actually waive the MIPS penalty for those groups that are moving towards APMs and demonstrating that they're doing that, but falling short of that target. So, you'll have to excuse me for using terms like close and almost, and that's just the law basically doesn't give a whole lot of details regarding that, and that's really what the rulemaking period is for, 2016 to 2018, where a lot of this is going to be hammered out. But yes, that is sort of considered in the law, that there is incentive to adopt some of those, and if you fall short, that maybe your fallout won't be as severe as if you had focused solely on the value model. Okay. I can take one or two other questions about that before I move on to the quality, before we move on to data, or I could save it to the end. So, all right. So now let me move on to the data piece. And yes, Steve.
You can repeat the question, but are there political implications of changing administrations or anything like that as we go forward the next year or so, and how might that influence this? Sometimes you get involved in this and just wipe it all out.
Yeah.
You have to repeat the question.
Thank you, Steve. So the question, Steve, Dr. Clements asked the question, and I guess I'll paraphrase, could this potentially be at risk for being wiped out, depending on how the political scene changes over the coming presidential election, and perhaps as Congress turns over in 2, 4, 6 years, et cetera? I guess yes, that is a risk. I might suggest that it's more theoretical at this point. I mean, ACA has been passed. It's been threatened on multiple fronts, multiple times. It seems like that's here to stay. Even if the federal government and certain parties may not agree, and they might threaten to repeal if they come into power, the industry is just moving too far in this direction of quality and value. Too many demonstration projects with systems moving toward the frontier of alternative payment models. I think the details may shift. There might be a little bit of a lag here and there in terms of how soon this is realized, if there are fluxes in terms of who's in power, et cetera. But I don't see this going away. So that's sort of, if I were to read the tea leaves, I think this is happening. It's going to happen. How soon and what the details are going to look like remains to be seen. Okay. So now, with that sort of in context, now we'll get into kind of a summary of recent data and our performance as a group and as an institution. And hopefully this will reassure us as a group that, one, we're in a reasonably good position for how we are performing in a lot of these metrics, and that at least we have, we can hit the ground, hopefully running, if not running, on pretty good balance and pretty good feet, to at least address these head on, and we're already doing that, a lot of these components. And then when I get to the acknowledgments at the end, I hope to highlight what a number of you are doing to really help this whole movement towards quality and value. Okay, so the University Health System Consortium is a group that we belong to at our Emory hospitals. UHC consists of 120 academic medical centers, and every year it ranks us in overall quality in 6 domains of mortality, effectiveness, safety, equity, patient-centeredness, and efficiency. All right. And we started this exercise in 2006 when our board basically decided we're going to participate in UHC, and we're going to put a whole lot of effort, resources, and leadership time in demonstrating how well we're doing. There are a lot of different rankings you could choose to be part of. we said we're going to be part of UHC because that's part of our identity as an academic health system, okay? So at that time, there were under 100 organizations, now grown to over 120, and we put in a lot of effort from 2006 to 2010 and didn't move the needle a whole lot. Okay, and this is often what happens when you start the quality journey is you invest a lot of resources and time, and if you give up too soon, you'll say, I'm sorry, this is going in the wrong direction here. You'll say, boy, this is not working, we're going to give up these resources, we're not going to move forward. And it's really, this is one lesson, it's a game of persistence at the division level, at the institution level, and finally, after 5 years of participating, our hospitals broke into the top 10. EUH for the past 5 years has been in the top 10, which is no small feat, because you might think, oh, we're slipping 10 to 2 to 8 or so to 4. Well, every year, the curve, the whole group gets better. Okay, the overall score of every group gets better. And so you're competing basically against more and more adept organizations as well. And so for EUH to be there 5 times in the top 10 in the past 5 years, and Midtown to also make it for 2 years, I think is a real testament to the commitment that Emory has made towards this. Okay. For the first time this year, our ambulatory scorecards have been released as well. And I'll summarize it here. Doug, please chip in if you have any comments about this. But, you know, Doug and Bill and others released an email to all of us that said, we're proud of the fact that Emory Clinic actually ranked 5th in the first time the ambulatory score came out. Out of 46 ambulatory practices, the Emory Clinic ranked 5th when 5 domains were included: access to care, continuum of care, quality and efficiency, capacity management, and throughput and equity. I don't have time to get into all of these in detail, but some of these mirror what's been happening in the hospital side. Other components are specific to clinic-based operations, and this is both exciting that we're doing well on the clinic side, and it's also scary at the same time. How did we rank 5 in our inaugural year, and can we do it again? Really, so that's kind of what remains to be seen as we move forward. But Doug and Penny for clinic leadership and all of the divisions to chip in have really embraced, they've mirrored the embracing of quality on the clinic side as the hospitals have done a decade earlier. The final ranking that I'll show here is the U.S. News and World Report. We were ranked 17 at one point, and then the whole methodology changed with a heavy focus on magnet and on quality. And so we were in the 40s, and then we jumped up to 16 last year, tied with Hopkins. This year we are now ahead of Hopkins as a cardiology division, according to U.S. News World Report. This is for cardiology and cardiac surgery combined. Okay, and so what's been responsible for this jump? It's been a combination of both magnet accreditation at EUH as well as gains in our quality score across the system. And that really has helped us jump into the top 15 as a division as a whole. All right. Now I'll highlight 3 different areas, okay, acute MI, cath lab, and clinic quality. A number of you have seen iterations of these slides in different talks. I've updated them and have put in a couple of other pieces that hopefully are of interest to the different groups. This is just an example of volumes at one of our hospitals at EUH, and every quarter we keep tally of these kind of graphs. Mary Casey, who's sitting in this room toward the back, you can raise your hand, Mary. Mary is our cardiology NCDR data registry manager, and she has been a real a force in terms of helping to not only generate the data, but her understanding of the data and what's happening and how it's going to translate at the institutional level is it's a cut above what I've seen at other institutions. Okay, so we're actually very lucky to have her here. So this is an example of the data that we produce. There's an STEMI graph. There's a STEMI graph, okay, in terms of what our volumes have been doing over time. This is somewhat representative of what's happening kind of at institutions across the country and certainly in Atlanta, where the STEMI volumes may creep down as more and more 24/7 PCI centers pop up, and the NSTEMI volume increases, perhaps due to more refined troponin assays, due to coding, and sort of a culture that really encourages any positive troponin to be coded as MI. Is that right? Is that wrong? It's, of course, a more complex answer than that. On the hospital side, you're incentivized to code as acute MI because that bills for a higher level than other causes of elevated troponin. On the other hand, it also impacts sometimes negatively the accuracy of our diagnoses that have clinical quality implications. And so there's always a tug between getting it right and the billing side. These are the heart attack measures that we look at through two different registries. NCDR, which is our action registry for NSTEMI and STEMI patients, and Mission Lifeline, which is STEMI only. That's American Heart Association's program that actually uses the action registry data and then synthesizes it in a different way to give us STEMI quality metrics. The metrics circled in red are the ones that are specific to each program. The ones not circled are common to both. Those are the ones you well know of: aspirin or arrival and discharge, beta blockers, ACE, statin, smoking cessation, door to balloon, etc. NCDR also looks at evaluation of LV function and cardiac rehab referrals. Mission Lifeline looks at first medical contact to balloon within 90 minutes. That's the new metric. Well, now it was actually proposed in 2007, so it's actually not that new, but in terms of centers implementing it, we really started implementing in 2011 onward. And so that's really the tall order from the time paramedics arrive at the patient's side with the STEMI in the field until balloon inflation. That's 90 minutes. Every time I stop and think about that and repeat that, I'm like, that's really hard to do, okay? We may be on our case in terms of we got to do this, et cetera, but that's actually really tough to do. From the moment you arrive at the patient's side, you have to recognize a STEMI, diagnose it, get that ECG transmitted, or call the ED saying, you know, we have someone with a STEMI. The ED has to trust the EMS report, activate the cath lab. The cath lab has to trust both the ED and EMS for having made that right call, come in, and then do the case. And if door to balloon wasn't enough, they're like, yay, we got door to balloon solved. Sorry, now FMC to balloon is there. It's really sort of been a major challenge, and our group has really risen to the challenge, as we'll show here on some of the data slides. If you were to take all of these metrics and condense them into a composite, this is what the composite would look like. There's an EUH STEMI composite. Well, so all the hospitals have this. We keep track of this for all 4 hospitals across the system. For the interest of time, I'll just highlight, again, one hospital here. But there's a STEMI composite and an NSTEMI composite that gamishes all of those individual metrics. And every year we've been consistently better than U.S. median, well above what's required for recognition. Okay. This is specifically the FMC to balloon metric. Down here is the quarter, every 3-month period. And on the y-axis is the proportion of STEMI patients meeting the 90-minute FMC to balloon target. This was all the activity that we undertook for the first 2 years to get on board with this, participating in the registries, installing software to receive transmissions, training of ED, training of EMS, inviting EMS to our meetings, and then encouraging the ED physicians to activate. And so early on it was kind of tough. We were all over the place. It was not very easy. And then we persisted, and we managed now consistently to most of the time get above 90, to do better than the 90-minute target in 75% of patients. We do that on most quarters. And most of our hospitals have done it very consistently. Even St. Joseph's now, that had sort of separate processes. They have a competing academic center, or I'm sorry, a competing center, excuse me, not academic, but a competing center right across the street. So, but they've now also managed to get in there a couple of times in the past year. And so really as a system, we've made great strides in this, where this is really, you know, a consistency game. And I think in the quality improvement literature, it suggested that 7 data points, if it's hitting a target, is good enough to call a trend. Not 3, not 4, but 7. Okay, and thankfully now we've hit 7 for EUH Midtown and Johns Creek. And so I think this really is a testament to the group, our cath lab, our ED, EMS for working together to achieve this. And it's led to a number of recognitions from American Heart, from NCDR, and from accreditations. Midtown and EUH both have achieved the highest level of recognition and accreditation, and we're the first two hospitals to achieve this actually in the greater Southeast affiliate of American Heart, which is a 7-state region. And so that's been a nice feather in the cap for our programs. Now I'll change gears to interventional cardiology, okay? And there is simultaneous pressure to maintain volumes and at the same time to avoid doing unnecessary procedures. Our group is being double squeezed, and there's no mistake about it, okay? The NCDR cath PCI registry, fortunately, is a tool that helps us to try and navigate this balance. There are 33 metrics in 4 different domains. Performance metrics, mortality, bleeding, and composite discharge meds are the 3 performance metrics endorsed for quality reporting, for public reporting by the National Quality Forum, outcomes metrics, process metrics, and appropriate use criteria, okay? And this is a very vital registry. It's the oldest registry in NCDR, dating back, I think, to 1998, and it's sort of the linchpin of NCDR. And public reporting, hospital incentive programs that we're now integrally a part of as part of our shared savings contracts. You get higher payment from certain payers if you're part of this registry and you do well in it. CMS is targeting appropriate use criteria. This is very clearly a mandatory registry to be a part of. I'll go through some of the selected metrics in terms of how we're doing. You'll see this format repeated on a number of graphs. This is quarter on the x-axis, risk-adjusted mortality on the y-axis. Right, and this is our performance quarter to quarter for each hospital. And you can see there's a lot of variation. This is not a large spread of a y-axis. Okay, the scale is only 0 to 4%. And one death can mean the difference between being here and here. Or if you're Johns Creek, between being here and here. Okay, so one death makes a huge difference, and it's a game of consistency. And when you aggregate our performance over the most recent 4 quarters, we're performing better than the US median. Okay. And I just want to make a comment about risk adjustment. That's fine. These are all risk-adjusted metrics. Risk adjustment is an imperfect science. Okay. The bottom line is, if you're a center that's dealing with high acuity, highly sick patients, you can adjust until you're blue in the face. You're not going to totally mitigate that risk in your risk adjustment. All right. So they make a valiant attempt, and it's a good attempt. It's one of the best models out there for risk adjustment, the NCDR risk adjustment for bleeding, for mortality, but it's not perfect. So we just have to keep that in mind whenever that's thrown back at us saying, well, it's risk adjusted. So, well, yes and no. All right. Bleeding is another metric that we're looking at, and very closely. This is perhaps the metric that is most in the limelight in the past year among the different societies, not just NCDR and ACC, but SCI and our cath lab groups are really heavily focused on bleeding. And all of our groups are having challenges with this. I'm happy to say in the past couple of quarters we've made some strides in bleeding here, and actually 3 of our hospitals are, St. Joseph's now has just squeaked under the median. Midtown and EUH have some work to do to get to median. Johns Creek is doing a lot better. I think part of that is an acuity issue. They also don't have surgical backup, and so that's part of it. But Johns Creek does also run a tight ship with their programs, and so not to take away from their efforts, they have done well here as well. All right. But this has been a deep dive for our group. We've had a couple of meetings now with our cath lab leadership, as well as with all of the interventionalists in our group, and we've gone over the definition for bleeding. There are 5 components: a clinical bleeding event within 72 hours of PCI. Any hemorrhagic stroke or tamponade post-PCI constitutes a bleed. Okay. Transfusion, where the hemoglobin is more than 8, or an absolute drop in hemoglobin by 3 grams per deciliter. It was never intended for this one, I'm told, it was not intended for this metric alone, for the absolute drop in hemoglobin. It was never intended for that to be a criterion by itself without being linked to an overt clinical bleeding event. However, in the translation of this whole thing, it became an independent criterion, such that if a patient drops their hemoglobin from 15.9 to 12.9, and they're doing totally fine, no hematomas, nothing, that counts as a bleed. They probably just got too much fluids. We all know that, okay? But that's often how this game is played. So we've had to respond to that. We've done a deep dive in terms of looking at all of the bleeds that have happened in year 2014. I'm not going to go over this in detail. I'll just point out here, these are the number of eligible PCI cases for each of the 4 hospitals. These are the number of bleeding events in the numerator, ranging from 1% to 8.7%. But then when you look down here, we started breaking it down. This is all a breakdown into the buckets, into one of the 5 buckets: clinical bleeding, drop in hemoglobin, transfusion, etc. And the take-home point here is that fully 40% of our bleeds at EUH in Midtown could be explained only on the basis of a drop in hemoglobin, with no clinical bleeding event associated with it, with no transfusion. And so this is really, it's just a number, okay, a hemoglobin dropping without any clinical sequelae attached to it. Transfusion alone is another 20 to 30%. Okay, and so fully 80% have no documented bleeding event associated with the drop in hemoglobin or the transfusion. And this becomes a little bit of a game then. Okay, well, how can we tweak our processes such that we can at least not be penalized for the numbers? And so our group has undertaken we've brainstormed a number of solutions. The immediate ones that we've implemented are we've removed from the post-PCI order sets, there are a couple of order sets, there is a box for post-PCI hemoglobin that used to be checked by default across the system. It's now unchecked, okay? So anytime someone gets a PCI and gets that order written, you're not automatically just ordering a hemoglobin, all right? Because we probably don't always look at it as a group after we order it. We just trust whatever's order is going to be followed by the floor team unless they remain on the interventional service. But so we've done that, and we hope that's going to continue to help. The real challenge is how do we now communicate with our floor teams, our CCU, the cardiology floors, our hospital medicine colleagues, our surgery colleagues to do better in not checking post-PCI hemoglobins without good cause. Okay, and maybe we're going to adopt a culture that's more in line with the orthopedic surgeons, where you'll get barked at as a house officer if you check labs that look for bleeding or other complications without the permission of an attending. Well, I'm not sure we want to put that burden on our interventional attendings, but maybe that's the kind of direction we have to move towards to say, you know, let's have more of a dialogue here so we understand what we're doing kind of as a group as a whole, okay? I'll just touch on some of the other slides here. Appropriate use criteria has been another big effort of our group. This is another annotated run chart. This metric is appropriate use criteria attempt to classify every PCI case as appropriate, maybe appropriate, or rarely appropriate. The old term used to be inappropriate, but the attorneys at ACC said you got to stop calling them inappropriate and call them rarely appropriate instead. So if your documentation is so poor, that means you can't even put them in a bucket, okay? This metric looks at that. How poor is your documentation so you can't even put it in a bucket? And our goal is to be as low as possible in that. And so a whole lot of stuff was done to try and improve in this, and we did better. Well, we just kept up with the median through all of this effort. And then, again, a game of persistence. By continuing to do it, happily, all of our hospitals have now enjoyed being below the median, consistently for EUH and Midtown and for Johns Creek. Again, they're affected by the law of small numbers. One case can put you over the curve. And even now, St. Joseph's, for the first time, having adopted our common EMR system and really kind of working with the community physicians, have managed to get under this median as well, okay? The proportion of elective procedures that were deemed inappropriate has also managed. This is another metric we look at. This is now taking a look at the elective cases, how many are deemed rarely appropriate or inappropriate. Generally, the lower the better here. I would say if your rate is 0, you're probably gaming the system too much. And this was never intended to say that your rate should be 0. The documents for appropriate use criteria specifically state that payers should not be using this to determine who gets paid or not for procedures. Sure, that's being ignored. Okay, so payers are going to use that, and they're going to basically look at your inappropriate rate, and they've been threatening to not pay you. Whether that's going to be the case for those specific procedures that are deemed inappropriate, or whether it's going to be for those who fall within or an outlier for this overall metric remains to be seen. Okay. Habib has been one of the physician champions, working closely with Lynn Whalen and Greg Esper and others here on our VAP clinical effectiveness stenting. There have been several initiatives. Three of them, a number of them actually have been clinical. These are three that are highlighted here. Our cath lab group has been working heavily on improving the rate of same-day discharges. We've gone from 0 in 2014 to 56 in 2015 by Valurudin use. By Valurudin, now the data are bearing out that it's actually not better than heparin with bailout 2B3A in terms of reduction in bleeding if it's judiciously used, and yet Valurudin is 400 times more costly. You're looking at maybe $600-700 per vial versus $3-4, for heparin use in the cath lab, and so an effort has been to drastically cut that down. Radial access has gone up in commensuration with that. Okay, that's been another big effort. Scorecards have gone out for the past 2 years in a row. We're about to release a third version of the scorecards to our interventional group. They get a scorecard like this, and then they see graphs where here is the individual physician anonymized, and they're ranked sort of from lowest to highest for 8 or 9 different metrics. This is one showing radial access, where some never do radial approach, some do it more than 60% of the time across our system. Okay, so that gives you an idea of cath lab performance. Now we'll get into clinical quality improvement, just kind of as a third area in the final few minutes. On the clinic side, one of the things we've been working on is to improve first the rate of LDL cholesterol control, and then also the rate of statin prescription. This most recent year, we've been trying to improve statin prescription among patients with CAD with a target of 89% for the clinic. Cardiology met that target. When you combine it with the rest of TEC, we were not meeting that target, and we were indeed pretty static across the clinic despite a fair number of efforts to improve. And then, what we realized is we need to do a deep dive and understand what are these failures about. And so we recruited 3 cardiology fellows to help review charts. We looked at 120 random charts of failures, 40 from cardiology, 40 from cardiac outreach, 40 from general internal medicine. And we asked the guiding principle, is there a true gap in care according to documentation? And we asked 5 questions in order. Does this patient have clinical CAD? Is the patient on statin according to a med list? Is there a reason for no statin documented? Is the patient's age more than 80? Is there any other reason for no statin that seems reasonable? Okay, and so if the patient did not have clinical CAD after the chart review, we stopped there. We didn't keep going. This was the hierarchy we used. And the long and short of it is the nutshell was a true gap in care, and based on documentation, was seen in only about 13% of patients. We're actually doing a final adjudication of about 30 more charts. That number might change slightly, but it's not going to change much, okay? I would say, to be conservative, maybe 15 to 20% might have a true gap in care. 80%, 80 to 85% don't actually have a gap in care. And this is how it breaks down based on our initial cut, all right? A real gap in care, 13%. Fully 1/3 of patients did not have clinical CAD. In some cases, there was no evidence of CAD at all. A test might have been ordered for rule out CAD, but the patient actually did not have CAD. Non-obstructive CAD that's asymptomatic should not be coded as CAD according to the statin guidelines. Okay, so the lipid guidelines, or the statin guidelines, I should say, clearly indicate that you have to have clinical CAD, MI, stent, CABG, documented TIA or stroke, angina, something clinically driving the statin prescription, not just an asymptomatic 20% lesion. If you as a provider want to give a statin to a patient with an asymptomatic 20% lesion, that's fine. No one's arguing to say that you should or shouldn't do that. But should you hold systems on the hook to say that you have to do that if they have not had a clinical CAD event? That's the question here. And then in some cases, there was only coronary calcium documented, no actual obstructive disease. A statin allergy or they were actually on a statin happened in 17% of cases, and that should have been caught and not been called a failure. It was documented in the notes in a number of cases why they were not on a statin, and yet because we rely on data pulls from a data warehouse based on discrete fields, that wasn't captured. And so the long and short of it is, based on this work and the chart review, the statin CAD metric had been part of our Emory Balanced Scorecard, by which our hospitals, leadership, et cetera, are assessed in terms of how well they're leading an institution to improve and how well divisions and departments are achieving their goals. And we realized, you know what, this metric shouldn't be on there. It's not ready for prime time. We're not yet ready for automated data warehouse-based extraction of data to track metric performance. I won't say for all the metrics, but certainly for some of them, and that includes those that rely on a CAD diagnosis because it's imperfect, okay? It's imperfectly coded. So with that, finally, I'd just like to acknowledge the group, and I'm already apologizing. I see some of you in the audience. I put this together kind of fairly late, said I really need to acknowledge some folks. If you're not on the slide, please forgive me, okay? And I'll shout out some of you that are not written on the slide but should definitely be acknowledged. All right, and so it's kind of a long list. All right, this was an attempt to get it on one slide as well, but just to quickly highlight some names. So Wissam Jabber has been in our interventional group working with the fellows. Henry Lieberman has really been tight with the documentation at Midtown. Mike McDaniel has been very instrumental in helping us question what we do from appropriateness and mortality. Now, Tanvir Rab has been a real champion of our acute MI program, our cath lab processes with Mission Lifeline, and he's also done a lot for nationally, being on the cath lab interventional group, one of the interventional committees, writing a paper on cardiac arrest, and now also he's going to be on a public reporting committee. Habib with VAP standing and with all of his cath lab leadership. Acute MI leadership includes ED, our ED leadership and physicians, Mike Ross from the ED working on chest pain accreditations as well. NCDR registries and group, Mary, Casey and her team, Corby, Vanessa, Donna, and Pam Roberson have been instrumental in terms of making sure that the integrity of the data get better and better and better. And the success of the program is largely because of the attention to detail they pay to the data. Okay, Daryl Todd from Midtown Accreditation, Lynn for her leadership of our overall nursing efforts. IS has another group, George Chang, Allison, Brian Wells. Hospital leadership has been very supportive. On the clinic side, Penny Castellano, she's provided some key information regarding the QRURs. She and Doug have been real leaders in terms of quality and accountability. Jerry Magorisk, as part of our group, has done a lot with the statin metric. Linda, please forgive me. You should be written on the slide 100%. Okay, you have been key and instrumental. John Douglas in the back should be clearly up here in cath lab attendings, particularly for his engagement in the bleeding. I think in the past few months, John has been instrumental with the bleeding metric and questioning, really engaging the group, how can we get better with bleeding? Cardiac rehab, Kathy Lee Bishop, if you haven't worked with her, she's an absolute gem for our institution in terms of a real champion for cardiac rehab, and Larry for his high-level vision in terms of where this is going and sharing a lot of what's happening on the cardiac rehab scene nationally. Angel, Andy, and Bob for their leadership, and both at the site level and overall bringing a lot of these metrics into the division and the Office of Quality. Bill Bornstein. Bill, by the way, sits on one of the advisory panels for how the MIPS group is going to be writing out the rulemaking over time. And fellows, Kunal, Brian, for doing chart abstractions. Eric Shin is actually writing up our experience for peer-reviewed publication for how we've improved in several of the cath lab metrics using sort of a system approach, and our hospitals have improved. And Joe Z, one of our research fellows, Joe Z is writing that paper. Eric Shin is writing the paper on clinic quality and the statin and CAD metric. If I have forgot to mention you, please throw a tomato at me. I apologize. This is just all I could acknowledge on one slide. Clearly, this is really a huge effort. So thank you for your attention. I'm sorry for going over for a couple of minutes. These are my final acknowledgments for the payment reform slides. It's a complex and moving field, and both internally and outside of Emory, I've had great collaborators and support from these individuals. Thank you very much.
Thanks, Abhi. Any questions?
Quick question on that 20% of people, when you look at the bleeding in PCI, we think are, sorry. So, I saw that 80% of the bleeding in PCI was actually, we think, not necessarily clinically relevant bleed. And the 20%, do we have a sense of what the rate of radial versus femoral, and was that below the average nationally or across the UH? And do we think that that's...
So 80% were not associated with a clinically overt bleed in the hospital. Could some of them have developed some bleeding that was subclinical and that's why they got transfusions? Sure. So I don't want to dismiss all of that 80%. But there's a large chunk that was really based on numbers. And our radial rate is probably on the order of around 30-35%. That's lower than where it needs to be. The U.S. as a whole has a lower radial rate than the rest of the world, okay? The Europeans, the Chinese, I mean, some of these groups are really pushing the radial frontier, and we're laggards, quite frankly. The U.S. are lagging behind the rest of the world in the radial approach. And I think we've made strides as an institution. We're getting better. There are some centers that are pretty aggressive in the U.S. that are 65, 70, 75% radial. Some would quote higher. We have a challenge where we're a large health system. We have, I think at EUH in Midtown, we now have a radial-only approach. Habib can correct me if I'm not summarizing this to detail, but we have a lot of complex patients for whom radial is not necessarily wise to do. Cabbage, CTO, end-stage kidney, bifurcation lesions, et cetera. And so, for those, when you know you're going to be dealing with that, you don't want to stick the patient twice. You go femoral for those. And the radial metrics are not necessarily adjusted for those kind of things, although the data for the scorecards that Mary and I are working on will provide high-level data, and we are beginning to dig into some data to provide some specific data when you exclude those complex patients.
And Navi, I just want to applaud you on looking into the statin data, because I think there are a number of things that come out as comments about. Example would be readmission for heart failure, that 40% are preventable. And then as people start looking into it, it's actually, well, maybe 15 or 18% might potentially be preventable. And your biggest determinant of readmission for heart failure is actually your zip code and your socioeconomic status and that sort of thing. And as we look at these different things, I think it's going to be up to people like you and others to say, look, this metric may or may not actually make sense. And it's really digging into that data and saying what does make sense. So thank you so much for your work. We'll conclude here, but Abhi will be up here for questions.
The preceding program is copyrighted by Emory University.